Okay, our next speaker is Dr. Vishal Kapur, and he's going to be talking to us updates on endovascular interventions. Thank you.
Awesome. Thank you. All right. I guess before we start, beautiful. Thank you, Beth. Thank you for the invite. So, all right, let's go. Where's my ticker? All right. So, we should love our nurses always. Do you know why? The question is why? Because they decide your catheter size. All right. Okay, so I'm just going to give you a brief background on PAD. I mean, I'm sure you've seen a lot of patients with coronary artery disease, but remember, it's a cardiovascular disease. So there's always a vascular component to cardiology or the cardiovascular component as well. So most of the patients who present with PADs essentially are asymptomatic. They're also a manifestation of the atherosclerotic cardiovascular disease. Most of the times they're stable, but sometimes they do present with worsening of symptoms such as gangrene or critical limb ischemia. Just to give you a background, I'm sure you're going to see whenever you see patients or screening them for going into the lab or follow-up as an outpatient, you see this ankle brachial index or ABI, which is an important component of diagnosis and treating patients with the PAD. So just to give you an overview, any number between 0.4 to 0.9 is essentially curtails to claudication. Anything less than 0.4 is significant towards critical limb ischemia. So something to consider into when you're taking the history and the management of these patients. And the reason we do ABI essentially is because there is a method to the madness. There is a direct correlation between ABI, which is ankle brachial index, and mortality. So as you can see on the graph, the way it goes left towards the y-axis, the lesser the number, the higher the chances of mortality. So if your number keeps dropping, your chances of having an all-cause mortality of cardiovascular disease is higher. And so is the thing when you go extremely light. If the numbers are extremely high, again, there's an abnormality right there. So like I said, most of the disease process is stable. Approximately 16% progresses to worsening of PAD into critical limb ischemia, requiring further intervention. And this is the normal flow of a patient who's presenting with claudication. You can clearly see if you just follow them purely based over the period of time, you can see that survival in the next 10 years, the survival goes down to less than 60%. So it is a pretty significant abnormality, and especially worse in patients who are presenting with diabetes and who have PAD. You can see their mortality over 12 years, they do the worst as compared to somebody who's not a diabetic and not a PAD. So let me talk to you about some devices and instruments you hear about we use and latest technological advancements. So this is what we call as atherectomy, which is what is known as plaque modification. As you see in the coronaries, they do, like SS will talk about rota and orbital atherectomy. There are way more devices present in the peripheral world which actually can be used at a much more aggressive pace. So some of them are on the screen. So what usually it curtails is having mainly four categories. One is directional atherectomy, which is where you can actually direct your devices to a particular location, whether medial, lateral, anterior, posterior. One is orbital atherectomy, which actually spins around in orbit and gives you the luminal by shaving all these devices off. One is the laser atherectomy, using of laser technology. And one is rotational atherectomy, which is the rota. Directional atherectomy, like I talk about, it's removal of plaque from all the arterial walls. You can actually control it, you can direct it, you can control the speed, the velocity you actually go through, and it's approved by the FDA as well. This is one of the common directional atherectomy devices used by Medtronic. It actually comes in, as you can see, with a battery and the catheter as well right here. And what it does is, this is the real catheter in motion. I don't think the video plays if it does. Probably doesn't, sorry. So, but actually what it does is actually cuts your walls of the plaque, and you can actually determine if there's plaque, only eccentric plaque, so you don't have to, you can actually move away from the normal segment and just cut the eccentric plaque out. And the device was approved based on the definitive LE trial, which essentially says that if you use this device and as compared to a PTA arm, it actually does much better in patients who are claudicant. You can actually see, depending on the lesion length as well, less than 4 centimeters, 4 to 10, and greater than 4 centimeters, they did actually very well, especially in the diabetic arm as well. Both infrapopliteal, popliteal, and the SFA segments, you can see the primary patency. What it means is, what are the chances that the lesion you treated remains open at 1 year is pretty significantly high, especially it's 90% at 1 year as compared to just plain old balloon angioplasty, which is around 53%. And same thing, patients who present with critical limb ischemia, if you use this plaque modification techniques and compared to PTA, you can see that you can salvage the limb in 95% of the people over 360 days, which is almost 5 years, as compared to secondary patency of 88% onwards. There are another all the trials which have consistently proven that directional atherectomy, especially in cases of death, complications, patency rate, perform much better as compared to plain old balloon angioplasty. The other devices to look at is what we call as the orbital atherectomy, which is mainly by CSI, Diamondback, and now CSI has been taken over by Abbott, so hopefully it'll become Abbott down the lane. But this device, essentially what we are talking about is, I'll let it play faster if it can. Hold on, let me see. But what it does is, as you can see, there's soft plaque right there. You have the devices go through, so they actually go in and they spin around in orbit. So they're not only spinning the wire, but they're actually spinning in the whole orbit, and what they're trying to do is shave off the plaque by using this orbital mechanism. So here their claim to fame is that they only affect the disease segment while causing minimal or no trauma to the non-disease segment. So you will still see complications, whatever they claim that things don't happen, perforations, complications can happen with any device, but essentially it's known to work very well in patients who have significant disease. And also the idea is to try to churn all these particles down to less than 7 microns, which is the size of an RBC. So technically you can be absorbed in the RBC while having no distal embolization. So that's one of those devices which we have been used recently. The next one you're going to see is the use of a laser, which has been there for a long time, but it's actually very beneficial in the peripheral arterial disease. In the coronary disease, you use it if it's a very complicated lesion or an instant restenosis, but in peripheral arterial disease, we use a lot of these devices very commonly, especially in instant restenosis. So you can see, based purely on the laser and the energy, it actually just destroys the plaque. On the left is more plaque burden, and after use of laser, this using microscopic PET, you can see there is more luminal gain and better plaque as well. So it's actually proven clinically that if you use a laser device with balloon as compared to balloon alone, you can actually see it's safer and it is actually more effective, both from freedom from additional stenting, making sure that the lesion doesn't come back and you don't have to treat it down the lane. It has better patency result, procedural success, and of course, decrease from stenting. In cases of what we call as the EXCITE ISR trial, which is instant restenosis trial, laser has proven beneficial as compared to PTA as well. The two graphs show a significant difference, the upper one being the use of the laser, and the lower one being the regular PTA. You can see the probability, the survival is much, much better when used in concomitant with laser and balloon angioplasty alone. This I'm sure you've seen in coronary as well, but peripheral rotational atherectomy is used in peripheral as well with the same concept, but in this case, it doesn't spin around a longer axis, it spins around the wire, and the concept is essentially having these diamond-coated cutters, which is more anteriorly, so we shave the plaque out as we go through the plaque lumen or the lesion, and thereby causing to improve the luminal gain and helping further definitive therapy, which might be stenting in most of these cases. This is one of the newer devices which I'm sure everybody is now familiar with. Everybody's getting used to it. It is becoming very common and very effective, is the intravascular lithotripsy or shockwave. Again, all the data is coming from use of lithotripsy, which was initially used in the kidney stone. So what they're trying to essentially did is they create sonic pressure waves. So it's mainly electrical current changes into sound beams, create this pressure, and the idea is to crack the calcium. So it's not about plaque modification where you're shaving or cleaning or bidirectional orbital or rotational atherectomy. In this case, what you're trying to do is increase the elasticity of the vessel. So the calcium cracks up, the vessel becomes more elastic and pliable, and now you can expand it to get a better luminal gain, as well as trying to put a stent in. Remember, all the calcified lesions, the problem which we'll keep talking about is calcium is your enemy because you cannot expand your vessel. You cannot get that luminal gain. And if you don't have a luminal gain and you do definitive therapy like stent in an under-expanded vessel, the results are horrible. So what happens with intravascular lithotripsy, like you see here, is they have a delivery catheter, they generate sonic beams, they crack the calcium, and now you can easily expand it. So this is just a microscopic version of how you can see the cracks appearing in the wall as well. Let's see. So it's pretty much the same animation they have. So what they essentially the catheter curtails is you'll see these what we call as emitters present at a certain fixed distance, which emits these beams. So the central emitters have the maximum intensity. So if you're going to see us hit at one lesion and get the emitters up, pull it up or push it down a little bit to get in the center of the lesion. So the idea is try to crack it. So if we get the center emitters in the middle of the lesion, that's the most effective length. So usually comes in different sizes and different lengths. And what it does is, like as you can see, it goes through the wall. The energy conducts not in the lumen, but actually into the media and the adventitia, thereby sharing and cracking up the calcium right here. So it's a very good, effective device which we've been using recently. We talked about the mechanism of action, so I'm not going to repeat it. But again, it's again a demonstration of how you can see the emitters. You can actually, sometimes what you can see is, as a nurse, you'll see these paced rhythms on EKG. So it's nothing to be concerned about. You're not really pacing the heart. It's just because of the electronic simulation where it generates the electrical activity is generated, where it shows as an EKG being paced, but otherwise it doesn't. And here you can see on soft tissue, it doesn't really cause much harm. However, in heart, it does crack the calcium as well. This is the regular catheter you're going to see with the emitter. Usually it's 30-second emissions. In peripheral, I know coronaries is 10 seconds. In peripheral, we have longer because we don't really care. I mean, there's not much occlusion of the vessel. So it goes 30-second counts with the connector cable, and you can use it multiple times depending on how much energy they have. It's right here. It comes in 3 different formats: the large size, the medium size, and the else, depending on where you're going to use it. Applications we talked about, and these are certain clinical trials just to go over of where all this data comes from. So they did the trial in the coronaries, they did the trials in the peripheral. The peripheral trials are known as the disrupt trials, PAD1, PAD2, PAD3, and below the knee. So based on these trials, it was clearly proven that the primary patency was much better, as well as the secondary patency. Here you can see the procedural success by using IVL was much better, with a significant 25.56% superiority rather than a balloon angioplasty at the site and the core lab. The pressure required for using a balloon was less than 40% as compared to PTA, and the reduction is dissection. Remember, all we're concerned about is mainly dissection, outflow, having good results. In periphery, the good thing is we don't stent everything. We can get away by stenting things because we believe in the concept of nothing left behind. So if I can just balloon it and deploy my drug-coated balloon, I really don't have to stent it. It's not the usual norms, which we want to prevent stenting or keep it for a future if it need be. So that's where this device and technology helps, where the chances of having significant flow-limiting dissection is less, thereby helping us do just drug therapy as well. Decrease embolization, perforation, and no flow as well. All right, I'm just going to skip this because this is just the trial for it. Let's talk about some drug-coated balloons. So now, after we've modified our plaque, we just want to make sure, now what do we do? So like I said, the good thing in PAD is there's now what we have drug-coated balloon technology. In CAD, they just finished enrolling the use of drug-coated balloon. In Europe, they've been using in coronaries for a long time. But in US, the good thing is we're using these drug-coated balloons now for a longer period of time. So essentially right now in the market, FDA approved, there are 4 of them. It's Glutonics by BD, the Impact by Medtronic, Stellarex by Philips, and the Ranger by Boston Scientific. So what the idea of these drug-coated balloons is to deploy the drug. The main drug which we're using right now is paclitaxel. I know in coronary stenting and in regular stentings, you'll see we are into the Lima strategy. But in periphery or in drug-coated technology, we had to start from scratch and start using the paclitaxel. Of course, there are other issues as well. Paclitaxel easily binds to the balloon, so from technological R&D perspective, it's easier to use. So that's why I started with the paclitaxel first. But now they're coming up with the Limus trials as well. But this is just a basic background of how the DCB works. You have a coating process, you have an excipient, you have the restenotic drug, which in this case is paclitaxel, and you have a balloon platform. So not much variation between different balloons in the market. Lutonics uses a slightly lesser dose, while Impact and other devices use a little bit more stronger dose. I mean, Ranger is back to 2, but there is no real comparison to say one versus the other. Why is 2 better or 3 micrograms per millimeter square is better or not. but it's all dependent on how durable, how deliverable, and how much is the uptake on these DCBs that it happens. But the mechanism of action essentially is on the smooth muscle cell growth. So it inhibits muscle cell growth. Remember, the idea is that my plaque, my lesion doesn't come back. And the way it doesn't come back is because of the anti-mitotic, the activity of paclitaxel. So paclitaxel prevents the regrowth of the smooth muscle, which is the commonest culprit of these lipid lesion plaques. So Lutonix was approved because they actually proved that at 1 year, if you use Lutonix as compared to as compared to PTA, which is plain old balloon angioplasty, the patency, meaning the vessel remaining open at 1 year, is 73.5% as compared to 56%. So of course it works great. And the chances of you going back in and fixing the lesion, which is target lesion revascularization, the freedom for it is also equivalent or not inferior. So we're not causing much harm, but actually giving you more life to it as well. So they did it at the second year as well. The Medtronic impact balloon also showed much better results as compared to standard PTA arm, and all the different subcategories, whether it'll be death, no different. It wasn't more harmful. It actually did better in patency rate and the TLR as well. These are some of the global trials they did. You know, you do a randomized trial, but you also do a registry to make sure what happens in the real world. The trial is an ideal condition. You want the best patient, the best medication. You want the best result. But registry is where actually what happens in the real world. You want to see the data of when I open in the real world, how did the people respond? How did people use, and what was the thing? So in this case as well, the global trial, they actually showed much better outcomes, both at 1460 days, it was still patent, meaning the chance of the vessel remaining open did well, and the chances of re-intervening were very, very low. Stellarex balloon, which is again what we talked about, is the third balloon, also showed much better survival at 5 years. Ranger balloon, which is which is the fourth balloon we talked about, again shows greater patency rate, both at 2 years, freedom from revascularization as well. So there have been a lot of balloons which have worked great. This was the only real trial which compared one balloon to the other balloon, which is the Ranger DCB, which was 2 micrograms versus the impact, and it showed that there was not much difference between the two arms per se. So drug-coated balloons have become our to-go definitive therapy, but of course, in lesions which are non-yielding, in lesions which are very calcified, in lesions where we have flow-limiting dissections, then we move on to the stent part and see how stents can help us or treat using them. The issue with stents is it's simple, quick, and reasonable patency rate. The problem is, of course, it's expensive and it's early regeneration as well. We have different categories of stents: bare metal stent, which will again self-expanding, balloon expanding, drug-eluting stents, which is Zilver, PTX, and Eluvia, and then of course covered stents. I'm just going to talk about the drug-eluting stents right now. 2 in the market, which is Zilver, which is made by Cook, and Eluvia. As well, which is made by, I think, BD. Oh, yeah. So Zilver it's a nitinol stent used in the SFA. Again, it uses paclitaxel. We're back to the basis of using paclitaxel. Same ingredient as Corny was done. And and from their trial, they clearly showed that if you use a Zilver PTX versus a balloon angioplasty with stenting, you can see the primary freedom from revascularization. So at essentially 5 years, 83% of the patients do not get an intervention, while if you do a balloon, you get 67%. So pretty significant difference in the freedom from revascularization as well as primary patency. So the medication does work if used appropriately in the right way for patients who need these stents as well. Again, bare metal stents they compared does better. Balloon angioplasty, they do better. Patency, they do better. And this is for the Eluvia stent. Again, coming up, comparing Eluvia with bare metal stents, they also proven that they do much better primary patency-wise in the first and the following years as well, all the way down to second and third year. Eluvia, when compared to Zilver, now you can say which is one stent better than the other. There was one trial which compared Imperial trial, which is Eluvia stent versus the Zilver PTX, and they actually did end up showing some benefit of Eluvia stent at the end of 2 years. But overall, the safety point, the all-cause mortality, everything was pretty much similar, except for more instances of reintervention in the Zilver as compared to the Eluvia arm. Just one more thing to talk about is the Supera stents. I'm sure you've heard about these stents as well. They're the self-expanding nitinol stents. The good thing is they are these flexible stents which we can use as these hinge points or flexion points, like we call about, because they are interwoven stents. So what happens is we technically are forming a stent in the body. They don't come free-form. They pretty much, you have to shape them. So you actually control the length of the stent depending on how you deploy or how you make the stent in the body. So the good thing is they're very flexible, durable, conformable, so we can use it in the popliteal regions. The chances of fracture are pretty much minimal based on the superb study trial, which actually showed the patency rate was great. The freedom from revascularization was great. The clinical success, all in the red, did very well with the superb trial. So this is what it is. Supera stent, you can bend it, doesn't kink. A regular stent can kink, fracture, bend, thereby causing you to have more restenosis, more chances of stent thrombosis, and everything else. I'm not going to go over the study results, but essentially what it shows is the problem, like I said, is you have to form the stent. So if you actually, let's say the stent is 120 millimeters. If you end up just deploying 100 millimeters, if you deploy 120 millimeters, the clinical results in the best. So that means the patency rate is 90%. If for some reason the stent elongates, it's supposed to be 120 millimeters and you end up to 150, 160, actually the patency rate goes down. So that's the problem with the stent, is you have to try to deploy it at its nominal length. Longer is the worst prognosis, shorter is not as good, and of course ideal gives you the best result. And then just to go over, the SFA trials and studies, you can see these are stents on the left, do great, whether it's the Supera stent, the Silver stent, or you can have your DCB balloons, which also do great. And then, of course, atherectomy has proven to give beneficial effects. The worst is the PTA. So if you do plain old balloon angioplasty, that's the worst result. That's, even though it's technically all the trials are compared to plain old balloon angioplasty, because that was considered to be the standard of care, and for doing any randomized trial, you have to pitch it against the PTA, which is standard of care. But nowadays, things have changed, so technically PTA is no more a standard of care. You have to have some therapy, maybe adjunctive therapy in the form of atherectomy, or using drug-coated balloon as your definitive technique, or your stenting as one of the definite techniques as well. So just to go over the last points, we do end up using covered stents as well, because sometimes in cases of complications, perforations, a high degree of calcifications, especially in the iliacs, where the chances of having complication of perforation are high, covered stents definitely need to be used, and those are just a special niche category. And like Raman was talking about, only rarely do we use them, but they do have their own niche if used in the right place. So thank you so much.